بسم الله الرحمن الرحيم. Diffuse alveolar hemorrhage. Causes of diffuse alveolar hemorrhage. There are multiple causes. One of the three underlying histopathological abnormalities is seen on the lung biopsy samples: pulmonary capillaritis, as is seen in systemic vasculitis, and antiglomerular basement membrane. Diffuse alveolar hemorrhage in acute respiratory distress syndrome, and alveolar hemorrhage in the absence of alveolar damage, as is seen in coagulopathy and elevated left-sided cardiac pressures. Bleeding into the alveoli is often a feature of a small vessel vasculitis of the lungs. Most of the blood tends to remain in the lungs and is not expectorated. Patients with diffuse alveolar hemorrhage may have a background history of vasculitis symptoms over the preceding weeks to months. They can present with slowly progressive dyspnea with hemoptysis or be acutely unwell and hypoxic or be acutely unwell with hypoxia. They may require ventilatory support. Causes of alveolar hemorrhage include: the first three are common: anti-GBM disease, Goodbasture syndrome, granulomatosis with polyangiitis, GBA, previously called Wagner, systemic lupus erythematosus. Then the other causes, which are less common, include the following: rheumatoid arthritis, microscopic polyangiitis MPA, progressive systemic sclerosis, polyarthritis nodosa, mixed connecting tissue disease, antiphospholipid syndrome, Behçet disease, essential mixed cryoglobulinemia, endocarditis or tumor-related vasculitis, idiopathic rapidly progressive glomerulonephritis, idiopathic pulmonary hemosiderosis, leptospirosis, isolated posi-immune pulmonary capillaritis, coagulopathy such as disseminated intravascular coagulation, the DIC, mitral valve disease, bone marrow transplantation, usually within 1 month. Drugs include abexizimab, all trans-retinoic acid, sirolimus, propyl thiouracil, propyl thiouracil, penicillamine, and cocaine. Chemicals include trimellitic anhydride and pyromellitic dianhydride. Clinical features and investigations of diffuse alveolar hemorrhage. Clinical picture of diffuse alveolar hemorrhage: there is abrupt onset hemoptysis, which is the most common symptom, and although this is not present in 1/3 of cases, also there are cough, dyspnea, low-grade fever, weight loss, arthralgia, myalgia, and there may be a history of chronic sinusitis, and other ANT symptoms. That's to say, the clinical picture of granulomatosis with polyangiitis, Wagner syndrome, examination of the patient with diffuse alveolar hemorrhage may reveal non-specific signs or may have signs of underlying vasculitis with skin rashes, nail fold infarcts, digital gangrene, episcleritis, corneal ulceration, epistaxis, nasal crusting, or deafness. Neurological signs may include mononeuritis multiplex, which should raise the possibility of vasculitis, and the patients may be restless, and we can find hematuria and proteinuria urine on urine dip. Investigations of diffuse alveolar hemorrhage include the following: arterial blood gases, which may reveal hypoxia, full blood count may reveal anemia, let's say decreased hemoglobin and decreased hematocrit, the clotting profile, C-reactive protein and erythrocyte sedimentation rate, creatinine kinase, a chest X-ray, which may show bilateral alveolar infiltrates, and it's difficult to distinguish from pulmonary edema or infection, and we should consider just high resolution computed tomography. Pulmonary function tests. Pulmonary function tests will reveal raised transfusion of the lung to carbon monoxide, that's to say raised KCO, as increased intra-alveolar hemoglobin is available to combine with carbon monoxide. Abnormal KSO if raised by more than 30%. If breathless at rest, they will not be able to perform this test as it requires breathing holding of an air, carbon monoxide and helium mixture for 10 seconds. This test can be used to monitor disease progression. Bronchoalveolar lavage, the BAL, shows blood-stained lavage which becomes sequentially more so with each washing. Cytology shows hemosiderin-laden macrophages. The renal involvement will need doing kidney function tests and urine microscopy, which may reveal blood and protein in the urine, and red cell casts, and raised urea, and there is raised urea and creatinine. Also, blood should be sent for urgent complement levels, anti-nuclear antibody, anti-nuclear cytoplasmic antibody PR3 and MPO, and anti-GBM antibody, anti-double-stranded DNA antibody, antiphospholipid antibody, and rheumatoid factor. We should consider biopsy for lung, kidney, if acute glomerulonephritis present, or other affected site if well enough to make a tissue diagnosis. Transbronchial biopsy specimens are usually insufficient to make a diagnosis of vasculitis, and a surgical lung biopsy may be required. The key questions in diagnosis of diffuse alveolar hemorrhage include the following. Is this isolated lung disease? If there is, is there accompanying renal disease? Are there other features of underlying disease, such as say ENT or joints affection? The management of diffuse alveolar hemorrhage include the following: admission of the patient to the hospital, supportive treatment with IV fluid, blood transfusions, and giving oxygen if necessary, and monitor paying particular attention to auto saturation and keeping them above 92% with auto therapy, and may need respiratory support with intubation and ventilation or continuous positive airway pressure, CPAP, monitor hemoglobin and transfuse if necessary, monitor urine output and renal function. The goal of management is to establish the underlying diagnosis, usually with tissue biopsy. Other treatments include plasma exchange, high dose steroids, and cyclophosphamide, and dialysis if required. That's all about diffuse alveolar hemorrhage. Thank you.